Thank you. My name is Matt Walker. I'm representing the West Virginia Independent Pharmacy Association and the West Virginia Primary Care Association today.
Matt, you raise your right hand for me, and you swear your testimony will be the truth, and the whole truth, and nothing but the truth. So help you God?
Yes, sir, I do.
Okay, thanks. Is Senator, or the junior senator from the 8th, would you like the floor?
Sure. Thank you, Mr. Chairman. And I think Ms. Dellinger did a good job of explaining the bill, and I think actually got to part of the reason why, but I throw the ball to you in that regard. So why is this bill needed?
Sure. Thank you, Senator, and thank you, Mr. Chairman. I think this bill is necessary, really, I would say, to promote transparency around a very, very complex issue of pharmacy and pharmaceuticals. And I tend to put the provisions of it into 4 buckets. I guess I'll use that analogy. And one is PEIA transparency. So our state health plan, hundreds of thousands of people on it, they use a PBM to process their pharmacy claims. It's bid out, and the winner does that for several years, and then it's bid out again, of course. And reps from PEIA have said over the course of the past decade that pharmaceuticals and pharmacy spending have become their #1 spending item in a very large plan. So I think that warrants transparency. In the past, and pharmacy bills of this nature have been considered for several years, 2017 until this year, I think have sought to bring some kind of reporting and transparency to that spending item, pharmacy and PEIA, while also respecting, the proprietary and confidential nature of that PBMs have and drug manufacturers have and pharmacies have, frankly, on pricing and things like that. So I think what this bill does, and I'm confident from my members' and clients' perspective, is saying that it will bring transparency to a very complex issue, which is reimbursement, rebates, networks that are in the billions of dollars in West Virginia. So that's really my first, I guess, the first bucket I would say for PEIA. The second bucket I would just label a patient rights bucket, and what I mean by that is the bill I think gives rights and choice to all patients in West Virginia as to where they can fill their prescriptions, period. And what I think it does effectively via what some people call the any willing pharmacy provision is that it doesn't force patients or really incentivize or penalize a patient for going to the pharmacy that they want. And if you wouldn't mind me giving an example, if a patient has their copay or some kind of cost share waived to use a mail order pharmacy or to go to an affiliate pharmacy, which I believe in the bill is a pharmacy that has common ownership with a PBM, those types of measures can't be used to steer, what I would call steer or force a patient to go to a pharmacy in place of an independent pharmacy down the road, for example, that doesn't really have that advantage to set, say, a copay limit or waive a copay or do things like that to steer them in that direction. I think that especially now with the pandemic going on, mail order pharmacy and digital things like that, measures where you don't have to be around larger groups of people are important, but I don't think that should be forced on patients. If they would like to go to their local pharmacy, they should be allowed to do that. And a network decision, say at a PBM or health plan level, shouldn't say to a local pharmacy, we're not going to allow your patients in your local community to fill at your store. So that's what this bill does, in effect, is protect that choice. The other thing that's included in the bill is the rebate provision. And I'll admit that's a very, very complicated provision, but I think it's a worthy goal to try to push prescription drug rebates from the manufacturer level as far down to the patient level at the point of sale as you can get. Because a lot of times these rebates are, how do I put it, they're taken, they're soaked up, they're grabbed before they really reach the patient's level. So if you take a drug, for example, I take an asthma drug that has a $250 drug rebate, a PBM or a health plan may grab that rebate, but me, who fills the prescription and gets the drug, really doesn't get the benefit of that rebate. And I think this some language in this bill and in other bills around the country is seeking to push those drug rebates down to the patients so we can actually impact cost share. What I mean by that are copays, deductibles, co-insurance, and even premiums at the beginning of the health plan when the health plan benefit plan is set at that level. So that's the patient protection. The pharmacy protection, and of course, for the pharmacies that I protect, they're keenly interested in this, is making sure that they can receive patients and fill scripts for their local communities, that a PBM or health plan can't say to a pharmacy, you are no longer in our network, and your loyal customers that have been coming to your store for 100 years can no longer fill here. They have to get a prescription via mail order, or they have to go to one of our affiliate pharmacies down the street or something like that. And that's very important to them, of course. It also includes a reimbursement floor. And this is very similar, in fact, almost identical to what our Medicaid program set in 2017. Our Medicaid program in West Virginia found that they had issues with reimbursement, with spread pricing, with rebates, and they switched the pharmacy benefit process from a managed care PBM model to a fee-for-service model that's done in-house at the state, and saved quite a bit of money. And I believe DHHR has testified to that in the past in front of this committee, actually. Our pharmacies really just want to be paid cost, which is what NADAC represents. It's updated differently depending on the kind of drug, but it is a national average of what a drug should cost. So what a pharmacy buys that drug for in Florida or California should be similar to what they can buy it for in West Virginia. So it sets cost and gives them a dispensing fee for their professional service on top of the cost, similar to really other professions that are paid for their professional service. So it's $10.49 per prescription that they fill on top of the cost. And what that really does is it sets a consistent benchmark and allows pharmacies to have some kind of certainty as they do business. A lot of states are moving toward this type of model. Medicaid programs all over the country move to this model, and the pharmacies here would be very happy to see that happen. And finally, the last piece I would say is a 340B protection for 340B covered entities that participate in the federal drug discount program. It's a program that allows safety net hospitals and health centers to buy drugs at a discounted rate in order for those drugs to be covered under the Medicaid program nationally.
All right, I got a couple questions just to follow up, and I really appreciate the explanation. I kind of got a handle on it. I think I do at least, or at least enough to make me dangerous. And I appreciate the 4 buckets analogy or illustration. So just when you talk about that bucket of transparency, you're basically what you're saying is what this bill makes clear, the interaction between these entities that are involved, the PBM, the drug company, the pharmacies, and the PCPs, correct? Mm-hmm. Okay, and that's a good thing. I don't know if anyone would disagree with that. And I understand and sympathize, I think, with what you're coming from with regard to the independent pharmacists or independent pharmacies, to the extent that my medications don't go through Walgreens. I get them through the mail, and I assume that's a consequence of it being cheaper to some degree from a wholesale entity. But what does this change? Does this reduce the cost on the patient or the person? Or does it increase it? I got a head nod from someone behind you, yes, but I'll let you answer that.
Sure, Senator. I think that ultimately the provisions in this bill will decrease the cost of prescription drugs. And the rebate piece specifically, if I could focus on that, anything that pushes drug rebates to patients will decrease their cost share. So, as you know, and you used an example of your drugs, someone is paying up, soon if you have health insurance, that someone is charging your health insurance for those drugs, and theoretically you're also paying some kind of cost share, maybe a copay or co-insurance or deductible, and you're certainly paying premiums up front to be a part of the insurance plan. I think the goal is to push these drug rebates, which are very shrouded in mystery sometimes. No one really sees them. They're proprietary. You don't get to know what they are. Uh-huh. Push them to the consumer at the point of sale to lower or even eliminate that cost share for patients. That is the whole goal, and I think this bill can achieve that.
And 340B, and I'm going to, Garb, you said those are 340B hospitals, or what? Can you explain that part of the bill again? Because I didn't catch it the first time. Sure.
So in 1992, there was a program created called the 340B Drug Discount Program. And what it sought to do is to allow safety net providers, and I use that, I should tell you, that means many hospitals in the state, most hospitals in the state, most, if not all, of the community health centers, also called federally qualified health centers in the state, they're allowed to buy drugs at discounted prices under that 340B program. They do that because they report and they have to be responsible for using those discounts to do things like reduce cost share for patients at the point of sale, for example, to open new programs of various types, transportation programs, addiction programs, school-based health centers, which there are 250 of in the state right now, many, many different wonderful programs that these safety net providers open as a result of buying these drugs cheaper, effectively. So that's what the 340B program does. And I think it's defined as stretching scarce resources from the federal level and trying to help safety net providers to offer increased access.
All right, thank you, Mr. Walker.
The Vice Chair for a question for Mr. Walker.
Hi, Mr. Walker. Good to see you in the real world. I just have one quick question for you. When this bill came to us from the House, the language in it gave the rebate or the discount to the patient at the point of sale. Do you think that was feasible in the real world?
I think that it can be done. Now, as far as exactly how that is done, I can't explain that to you. I think that ultimately will have to be done in order to get the patient the benefit of the drug rebates, is to push those rebates all the way down to the point of sale. Because there are so many things that happen between the time the rebate is paid to the time that the patient, say, may have their drug dispensed to them, they're not getting the full benefit of that rebate.
The Senior Center from the 17th.
Thank you, Mr. Chairman. Matt, two quick questions. This in no way affects what a payer would pay for medication in terms of, so for example, if you've got a plan that typically would pay for heart medicine and depending on the different pharmacies may charge different prices for that medicine, and then the cost that transferred to the patient, will the patient still have the same amount regardless of what the pharmacy paid for it, or would the patient's amount vary depending on which pharmacy they choose to go to?
Senator, I think patients end up paying different amounts depending on which pharmacy they go to. And I say that's kind of a broad statement, depending on whether they're going to a brick and mortar pharmacy, a hospital pharmacy, a health center, if they're getting it mail order. So, and that's part of really the issue around pharmacy. It depends where you go and where you're filling your prescription. That changes what your cost share is. And that's very confusing, I think, to patients. And it's one of the things that I think needs cleaned up, so patients understand what they're paying for their medicine, what their insurance might be paying for their medicine, things like that.
But if you've got a patient that's a thrifty individual and they've done the research and they find whatever pharmacy where they can get that drug cheaper based on their plan, they're still allowed to do so. They're in no way prohibited from going to whichever pharmacy they choose to, that they could get the best deal for themselves.
That's correct. One of the greatest things about this bill is it protects patient right to go to the pharmacy of their choice at all cost.
And then currently, do you know what the dispensing fee is that they're reimbursed right now in pharmacies across the state, or is it just variable? Or
It's variable, and I've actually polled this quite a bit with the 230 so pharmacies that I represent. Often pharmacies get no dispensing fee, or they get a few cents as a dispensing fee, and then sometimes they get a larger dispensing fee. But again, there's no consistency and there's no transparency, and that's part of what this bill is trying to remedy, and that is to tell pharmacies and patients and payers, for that matter, this is what a drug should cost, and this is what your fee will be for your professional service to fill it. And that's the sort of the overall goal.
Thank you. Thank you, Mr. Chairman.
Thank you. Mr. Walker, thanks. There's no more lights. Appreciate you coming.
Thank you.